a circle.
You can erase my space alien on the side.
No, I like the space alien. We'll probably use them. Any questions from from this morning? Jeff was that good. Okay, well we're happy to be here. I'm sure Jeff told you that we worked together for like exactly 10 years.
Yes.
And neither of us really think that that's possible, but it's true, totally true. So we think it's one of the best examples of how these things are supposed to work. So he keeps coming back every day. So that's all I can say. So we're gonna run through some of the same topics maybe that he touched on, and then we'll cover a little bit of hearing loss. I'll show you some of the zebras that do exist in the wild. So one of the things that I really had difficulty when I was in medical school and in residency is that never going to see any of these things. Well, somehow I make an entire living out of only doing these weird, wild, zebra-like things. So they are out there. One of the things that Jeff and I see pretty regularly is that you guys need to take every opportunity to make the most of the physical exam specimens that are presented to you. So, don't be too terribly shy about, oh, well, let me feel that rash. Let me feel that lump. Let me feel what that looks like, feels like, sounds like, because those zebra things are out there, and it's just you and you and the rest of the medical community out there trying to diagnose these things. So we'll do what I call the otology, neurotology potpourri. I did medical school, residency in ear, nose, and throat, and then I did a 2-year fellowship in neurotology. So I spend my life between here, just this little space here. And we'll go through there. So hearing loss is hugely prevalent, hugely prevalent. Can anybody name the 4 modifying risk factors that we know are present for dementia?
Hearing loss.
Good. Good. Very bright bunch. Very bright bunch. I mean, why would I ask, right? So, yeah, hearing loss. Is anybody surprised by that? Not surprised by it? Okay, I am. I am. So I'm terribly surprised by that, because what are the other 3? Anybody name the other 3? It's outside below the clavicles.
Outside the clavicles.
Okay. Meaning that it's not as easy as hearing loss. Yeah, so it's heart disease, okay, because disease of the heart is bigger than the heart, promise. It's obesity, and it's I can't, but hypertension. That's part of it's part of heart disease. It's diabetes.
Oh.
Okay, so all right, so the first 3 make sense, right? Everybody's got bad news with respect to heart disease, microvascular disease, diabetes, but hearing loss? So hearing loss is exceedingly important, and so what we know about hearing loss is that it isolates you, disconnects you, stops you from doing things that you're supposed to be doing that make you like life and like the people around you. And then you get depressed, and then you stop doing things. And when you stop doing things, if there's any theme of these 2 lectures that we'll talk about, is that when you stop doing things, that's really not a good thing. So hearing loss is a huge, huge problem. So for infants and children, it's about 1 in 1,000. We have a newborn hearing infant screening program. So when the baby is born, they do a click auditory brainstem response, make sure that both ears are hearing well. Those tests are designed to pick up more failures than are really present in the world, so that we retest people when people don't fall through the cracks. So your ability to understand and listen and hear is deeply tied to your ability to achieve in school, to maintain a job, to just be successful in life. 40% of people greater than 75 years old will have a hearing loss out of expectation for what we would expect. So there are slopes to the hearing loss that we would expect as just normal, badges of honor for living that long. But 40% of those people will have a greater amount of hearing loss than we would expect. So the middle age folks, they really need to be getting hearing tests so that we can help them not enter these paths for dementia. So, interesting observation. My severely impacted otitis media patients, cholesteatoma patients, I'm going to take out your eardrum and your 3 hearing bones, and we're going to give you a humongous conductive hearing loss. When those patients live their lives and go and make it to the age of 75, do you know what their nerve thresholds are? They're completely normal. So what that tells me is that our natural background noise, the stuff that we expose ourselves to in the world, is really, 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 really bad for the cochlea. So earplugs, earphones, if you're a shooter, you need to wear plugs and muffs. I don't care what you can and you can't hear. Anybody a hunter? Yeah, great, good. So you need hunter hearing protection. They're about $1,000. And people are like, oh my gosh, it's $1,000. And I'm like, don't give me that. Your gun was $1,000, and your scope was what? $1,500. And you're gonna whine at me for protecting your hearing for $1,000? No, you're not gonna whine at me. So, park on down past Cabela's to our office. We'll give you some hunter hearing protection. It's a very, very good idea. So, but these things that you guys are going to be on the front line of, like when you go to concerts and you're like, oh yes, I do wear my hearing protection when I go to concerts. And like if you're me, you have hearing protection that is specially made for you, so it's comfortable and you can wear it all the time. So it's not a bad thing to be 70 and not need to come and talk to me about hearing aids. Okay, so hearing loss, huge problem. Don't miss it, because it is it's kind of like a heart problem. I think I might have some chest pain. Oh, you should just breathe deeper. No, you get what? I mean, you get a chest X-ray, you get an EKG, you look into these things. So if they think that they might not be hearing very well, you need a hearing test. Okay, so here's our hearing loss audiogram. Audiograms are awesome. They are connected to these people called audiologists. And down here at the, pushing a button maybe, I don't know. Down here at the bottom, do I have a...
Try pointing it that way. Okay, use the mouse. No, just trying to...
Do I have a mouse on this thing?
Yeah, it's up there on the tip.
Oh, this? 2 hands. Okay, so down here the audiologist fills in what all of this gibberish up here means.
Keep your mouse in there.
Scroll over
It's
where?
on extended
Just keep
screen.
scrolling,
Oh, scrolling.
like roll it, I'll show you.
You can also use a stick to point out what you want.
have sticks? Awesome, like it. Down there on front.
There you go.
Oh, wow. Okay.
So now it's on your.
There's a stick.
There's a stick.
It's working.
Okay, great. Thank you. So here, there's this part where the audiologist will tell you what it is. Like, you have a severe hearing loss and you don't understand things very well. So don't think that you have to be a total expert to order tests. The audiologist will help you out a great deal. So Jeff told you this morning that there are very few ear emergencies, and one of the few ear emergencies is I have a one-sided hearing loss. Did he tell you that? He didn't tell you that. Okay, that's my part. So an ear emergency is I have a one-sided hearing loss. So how do you know that it's a one-sided hearing loss that you need to give steroids for and call an ear, nose, and throat doctor? Any questions? Any answers to that? Any thoughts? How might you test the patient in your office when they're sitting there saying, I can't hear out of this ear? And you look in there and you're like, I don't know, the ear canal looks great. Eardrum looks like it was painted by Dr. Netter. What might you do? What might you...
Tuning fork.
So back in the old day, we would take out our watches and we would let people listen to the tick, but nobody wears a watch anymore. So yes, we would use a tuning fork. So rubbing and talking, and can you talk on the telephone? Those are great things. But a tuning fork test is what we use. So we actually use these things. So every day I use a tuning fork in my office. I have an audiologist over here, and I use a tuning fork every day. Does that encourage you in any way?
Yeah.
It should, because it's important. It's important that you understand how these things work. So, asymmetric hearing loss. You need to know if it's a conductive hearing loss or a nerve hearing loss. So Nikki, have we done the Weber and the Rena?
Well, they were demonstrated. I don't know how much in depth they went into it, or
Okay.
how you tell what is what.
So yeah. So this is a source of huge confusion.
Yes.
But that's okay. We'll see if we can figure it out. So on the audiogram up here, on the box right here, there's a legend to tell you what is what. So the right ear are the zeros, and the left ears are the X's, and then we have bone conduction. So when you do your tuning fork test, you're doing bone conduction. Okay, so the bone conduction is going through the skin to the skull, and it's radiating to the cochlea. Okay, so it is ignoring the eardrum and hearing bones. So if you have a nerve hearing loss in the right ear, and I put the tuning fork on top of the head, where is the sound going to be perceived by the patient?
Right here.
Left ear. Is it the right?
Okay, so I am the patient. I'm looking at you, all right? So I'm sitting here. I say, I cannot hear out of my right ear. And the bone conduction, the tuning fork test, goes directly to the cochlea, directly to the inner ear. So it is an inner ear test. Okay? So, if I have a nerve hearing loss in my right ear, where is the bone conduction going to go?
The left.
The left. because the right inner ear is bad. So think of the nerve test for the tuning fork as going straight to the inner ear. Okay? So let's continue playing this game. So I say I have hearing loss in my right ear. You look in the ear, it looks great. Looks fine. So put the tuning fork up here and the sound goes to the left ear. That means that if there's no fluid or mass or lesion or trauma or cerebral spinal fluid leak or anything like that in the right ear, that probably is a nerve loss for that ear. Okay? Okay, so extra point question. If I take the tuning fork and I put it behind my ear on the right mastoid tip in this same condition, normal ear canal, no wax impaction, no fluid in the middle ear space, where am I going to hear the sound?
The left.
You're going to hear it in the left. That is because your skull is a universal conductor of sound. So it actually doesn't matter where you put the tuning fork on the skull. You can put it on the top, you can put it on the forehead, you can put it on the teeth, you can put it over here. You're going to hear it everywhere because it's a universal conductor. There's no loss of power from going from one side to the other side. Okay? All right. So now I have a right hearing loss. I can't hear out of my right ear. And you look in there and you're like, I think I see fluid. And then you do your pneumatic exam, and you're like, I don't think that moves very well. Okay? And then I put the tuning fork on top of the head, and where do I hear the sound?
Hear it louder in the injured ear. Hear it louder with the ear.
So I am telling you I have a right hearing loss. Where would I hear it?
Is it still the nerve issue?
No, it's
Is it still the nerve issue, or is it?
You tell me.
Oh,
fluid.
You tell me. So if I add fluid behind the eardrum, is that still a nerve issue?
No.
No, that's an eardrum, middle ear space. Things aren't working the way that they're supposed to now. So it's not a nerve issue, it's a conductive issue. So if I see fluid on one side, then where am I going to hear that with a conductive hearing loss? I'm going to go to the right side. This is where we lose people. Yeah.
Do you not hear it in the left at all, or is it just goes to the opposite?
Yeah. Yeah.
Right
the reason, and so the reason that it goes to the other side is because it's all about efficient energy transformation. So the fact that you now have water instead of air underneath the eardrum, you're actually increasing the efficiency of the energy transformation into the right side over the left side. So the left side is at a sound deficit. You can play with these things by putting a an earplug in your ear and doing the Weber and the Rena on yourself. Okay, so you're like, okay, I'm going to give myself a conductive hearing loss by putting an earplug in my right ear. And I put the tuning fork up on my head, and it goes to wherever the conductive side is. Or it goes to wherever the best inner ear is. Yeah, I mean, you guys, I mean, just add yourself to the long list of students throughout history who have marveled at how in the world is this possible. But it will help you understand and determine whether or not, gosh, I really think that this patient needs high-dose steroids for their sudden hearing loss. Okay, so up here on this picture that we have up here, the bone conduction is depicted by the brackets, and so the patient is staring at you, and so the right ear has the right bracket and the left ear has the left bracket. So that's how you tell the difference, unless you don't want to look up at the legend. So in this case, this asymmetric loss is all the X's are in one space and the brackets are in one space. So this is an example of a conductive hearing loss, because the bone conduction is at one level and the air conduction, represented by the circles, are at another level. And when you have air at one level and bone at another, we call that an air-bone gap. And this is the picture that the audiologist would send you for a conductive hearing loss. This is a picture of a asymmetric nerve hearing loss, or a cochlear hearing loss, sensory neural hearing loss. The bracket for the left ear and the X's for the left ear are on top of one another. And then the bracket for the right ear and the circles are on top of one another, so that's how we know that there's no air-bone gap. And the left ear is asymmetric with respect to the right ear. In ear, nose, and throat complaints, the whole head gets sick. So whenever you have a unilateral complaint, that is something that needs an explanation. I only have this lump on this side of my neck. I only have the inability to breathe through this side of my nose. I only have a problem with this ear. Those are things which need explanations for. There's comfort in, I got sick and both of my ears now don't hear well. I got sick and I can't breathe through my entire nose. I got sick and my throat is killing me everywhere. I look in your mouth and I see one tonsil that is bigger than the other. One-sided things are not allowed in ear, nose, and throat work. So this is a picture of somebody who needs to see us, and we would order an MRI because we would be looking for a central brainstem cause of why one side of the inner ear is not working as well as the other side. Okay, this is a picture of a mixed hearing loss. So the brackets are at one level, and the X's and O's are at a different level. And then the brackets are below the normal threshold, which is around 20 decibels. And so there's two problems here. There's a problem with the eardrum hearing bones, and there's a problem with the inner ear as well. Okay, so sudden hearing loss, that, we consider that like, oh, better talk to the ear, nose, and throat doctor. What we do is prescribe usually prednisone at 1 milligram per kilogram, which is more than the Medrol dose pack. And we taper that over about 2 weeks. We think that those are from viruses. We really don't know because the sampling of the cochlear fluid is difficult to maintain hearing if you suck out all the fluid in the cochlea, so patients aren't really up for that. So we have very few temporal bones of people who had a sudden hearing loss and died and donated it, and we have all the studies to show it. But it looks like that this is a viral problem. So a very good story is, I had a virus a couple of weeks ago, and then, I don't think I'm hearing very well out of my ears. Then audiogram, asymmetric loss, sudden change, we would give steroids and order their MRI 6 or so weeks after this event to make sure that this was not, or that we're not going to image any nerve inflammation in the cochlea or the vestibular nerves, because that can also look like something else I'll talk to you about. It can look like an acoustic neuroma. Okay, so the next thing people will come and talk to you about is I hear ringing in my ear. So ringing in the ear is exceedingly common. It usually is the result of hearing loss. Most of us have had ringing in our ears at some point in time, usually in association with noises that we should not have been associated with, but we've all probably done those things. Some people have debilitating hearing loss. Those are usually involved with folks who have pretty severe depression, pretty severe anxiety, pretty severe other coping difficulties. So just know that it can be severe. There's almost nothing that we can do about it. So if you come in and you say, I have ringing, crickets, buzzing, chirping, 2 sounds, 3 sounds, 12 sounds in my ears all the time, I don't have anything for you. There are thousands of medications when you look at the PDR that have tinnitus associated with the administration of those medications. The only one that is almost pathognomonic is aspirin toxicity. I have seen that once, and you have to take a lot of aspirin in order to induce that, like suicide attempt level of aspirin. So, patient comes in, do you take any aspirin? Yeah, a little bit. You can stop it and see if that helps any. It usually won't. There's a problem with how we do medication assessment. So we do all of those complication lists are generated by we're all going to give you this medication and you tell us what happens. And so if you say, I think my big toe hurts, then great toe pain is going to be listed in the PDR as a possible side effect of this medication administration. So the fact that nearly everybody has tinnitus and lots of people are on pretty complex medications, it doesn't help us to eliminate those medications. You're not going to find a hypertension medication that doesn't also cause or eliminate the possibility that you're going to have ringing if you're a 75-year-old guy with hearing loss. Okay, so we get excited about tinnitus when it's what? One-sided, right? Or if it is pulsatile, or if it's fluctuating. So there are lots of cranial nerves that go through the external auditory canal and the middle ear and the internal auditory canal. So 5, 7, 9, and 10 innervate the external ear and the external auditory canal. 9 and 10 go across the middle ear promontory, and then you have 7, the facial nerve, you know, the cochlear nerve, and the taste nerve, which goes down the internal auditory canal. So you have lots of sources of irritation that can cause ringing. Hyperdynamic states like pregnancy, hyperthyroidism, anemia, they can all cause things. Hypertension, heart disease. You know, you can get, I've had patients come in and are like, I am being driven crazy by this sound in my ear. Look in and, you know, they had a haircut and there's like a little hair laying across the ear, and take that off and they're like, oh, it's gone. Yes, I am that good, thank you. I'm like, I don't know, whatever, okay. I would not have predicted that that would be that much, but okay. Aminoglycosides, so we are in a society of overuse and overprescription of all sorts of antibiotics. So when you really get sick and you really need something like an aminoglycoside, you might have hearing loss, you might have dizziness associated with it. Anybody who, you know, if any of you guys end up working for oncologists, in my humble opinion, everybody who's going to start chemotherapy needs a hearing test before they start, because a lot of those chemotherapeutic agents, even the ones that don't have it listed in the PDR, have hearing loss as a complication from them. So tinnitus is just, you know, miserable condition. Masking. Masking helps. So if anybody like, oh, you know what, when I go to bed at night, I do hear a high-pitched ringing. Well, you probably don't hear it now because you're listening to me and there's background noise in here and things going on and your mind is distracted. So masking, playing music that, you know, gives the brain something to do instead of acknowledge the fact, oh, there's a tone in there and I don't like it. It's a downward spiral. You know, there's a tone I don't like. Then you just are like, oh, I really hate that. And, you know, it's not like a sensation of brownies and ice cream. If that were the sensation, nobody would come and see us. But it's a miserable thing. So unfortunately, we don't have anything outside of masking. Use of hearing aids, which is another form of masking. There are some retraining programs that you can attempt, but I have not had anyone really dedicated enough to those retraining programs to make those really work very well. Yes?
What about, I see commercials all the time about pills you can take to help the ringing. Do those help at all? Have you seen any of those, like,
oh, yeah.
commercials and ads?
Yes. In America, you know, connected to where we are connected to, it is so difficult to achieve a magnesium deficiency, calcium deficiency, that would be significant enough to cause those things. Yes, try them. My rule is, you know, it's not going to hurt you. Give it a shot. Try it. Is there any consensus? Absolutely not. Am I the one doctor who says you should not use, you know, those things? Yes. You know, you should eat a healthy diet. You should take a multivitamin, and those are gonna. You're just gonna add stuff that you're gonna excrete. Is the usual case of that. I mean, there are deficits that need to be replaced, but you know, folks come to me and they're like, yes, I've been on B12 shots for, you know, like, yeah, probably excessive use of those things. How's that? I don't know. If it's not going to hurt you, then go for that. Treating the depression really helps. Okay, so I have a one-sided hearing loss. I have ringing in my ear. Is a good reason to get an MRI, because on that enhancing MRI study, you might have a big mass growing from your internal auditory canal into your brainstem, and this is what the picture of an acoustic neuroma would look like. So, so here's the internal auditory canal, and this is the brainstem, this is the pons, this is the cerebellum back here. So this is the cerebellopontine angle, and this is an acoustic neuroma in that cerebellopontine angle. So this is a good size acoustic neuroma, it's 2.5 centimeters big. So these, these happen. We usually find them at much smaller sizes now because MRI is not a rare study. You know, places used to not have MRI machines, but you know, there's an MRI. There's probably an MRI machine within 2 miles of this place. So they're everywhere. So we usually see them much smaller than this. But these things exist. They exist with one-sided hearing loss and ringing in the ear. So if somebody comes in and says, I only have ringing in my left ear. So hearing test, likely an MRI. Okay, so Jeff talked to you about cholesteatoma. Okay. So in Oklahoma, we're a very allergic state. So what happens is that your ear actually begins at the tip of your nose, and anything that can affect the front part of your nose can affect all the way to the back where the eustachian tube opening is, and you can develop inefficiency of the eustachian tube to equalize the pressure, and you can pull your eardrum towards the middle of your head, around the corner of the ear canal, and the outer layer of the eardrum being skin. Skin can get trapped, and it can grow to cause big problems. So we call cholesteatoma skin in the wrong place. The right place is supposed to be on the surface of a tight eardrum and not trapped underneath the eardrum or around the corner of the mastoid. This, it's just a really, it's a big problem. This is all I do, seeing folks with cholesteatoma. Chronic eustachian tube dysfunction is the biggest cause of the cholesteatomas that I see. So I do a tremendous amount of allergy treatment, trying to keep people's eustachian tubes working as best as possible. So the top part of your eardrum in the pars flaccida is a little different than the rest of your eardrum, and so you can pull that portion of the eardrum back on top of where the neck of the malleus is, around the corner of the ear canal in this place called the scutum, and you can accumulate debris up around the corner of the ear canal into the space behind the ear called mastoid, and you can get to come and see me. So graphically, this is what it looks like. So let's see if we have some other pictures here. So this is a severely atrophic retracted tympanic membrane, so that we see all of the hearing bones that we're not supposed to ever get to see. So here's the long process of the malleus. The cone of light I never talk about. It is often mentioned, but I find it, very, very not too useful. So if you can see it, I think it might help you just, at the beginning to think, yes, I am looking at the eardrum. but people are like, oh, the cone of light is short. Okay, great. Well, let me tell you, that cone of light is normal, and there's a lot of other problems there. So don't just stop at the cone of light. Here's the malleus, the first hearing bone. First hearing bone is in the substance of the eardrum. Here we go. And this is the end of the first hearing bone. And then this is the short process of the malleus. And then the eardrum, here's the bone of the ear canal, and this eardrum is pulled up around the corner of the ear canal onto the surface of the incus, the second hearing bone, the anvil, and then this is the long process of the second hearing bone. This is the stapedial tendon. And this is the crura of the stapes. So this poor little eardrum is retracted way down onto these hearing bones where it's not supposed to be. So we see these things all the time, and a lot of these patients will just say, well, I just have some fuzziness, some stuffiness in my hearing at the beginning of these problems. So carefully examine is all I can say. So here's retraction in fluid. So here's the eardrum pulled down. It's sitting on top of the incus. So we call this a meningoincutopexy. And there's fluid here as well. This is my encouragement that the other big thing that we want you to go away with is that there's lots of stuff that is around the ear. It's kind of a way station for the transition of lots of different structures. So in your ear, when I was training, I had a guy, Sam Levine, my otology preceptor, said it's a box with death on 5 sides, and it is completely true. So at the bottom of this box called the middle ear space, we have the jugular bulb, which carries all the blood out down into the jugular vein. We have the carotid artery coming up in the front part. We have the eustachian tube, the facial nerve, the tensor tympani muscle, the scabidial muscle, the inner ear. The brain is above, and the sigmoid sinus is behind. So we have just a lot of things going on here. So when you look at an ear, just think there could be more going on here than just an ear infection. So Nikki's claim to fame in Jeff and I's clinic is dragging a patient down the hall. Something ain't right here, and the patient had a glomus tumor. So don't think that these things are not, or you're not going to see just weird, wild stuff. So this is an eardrum that's pulled towards the middle of the head. There's fluid there. You'll see lots and lots of tympanosclerosis. So if you are someone who I had tubes when I was a kid, let everybody in the classroom look at the scarring in your eardrum, because this is just normal scarring from the eardrum being inflamed from ear infections and being terribly pushed and pulled. Embryologically, the middle ear space, just like there are lots of structures that come up and we sort of touch the corners of the box, embryologically, the cochlea and the temporal bone are adult size at birth. So when we can do a cochlear implant in a baby, we're going to do that cochlear implant as soon as the anesthesiologist is willing to put that child to sleep. So if we were in Australia, we would be doing cochlear implants on babies who are 6, 8 months old. The FDA in America says you can't do that until 12 months old, but we do them as soon as we can get the baby into the operating room. So the temporal bone is adult size at birth. So your eardrum and your cochlea don't ever grow. Everything around them grow, but they don't grow. So because you have lots of different types of embryological structures touching one another, and just the fact that the ear canal fills up with skin during development and then canalizes, you can get skin trapped underneath the eardrum in a congenital clusteatoma condition. This looks like a pearl in the anterior superior quadrant. So it's nearly pathognomonic for a congenital clusteatoma. So something in front. This picture is in the surgical position, so the patient lays down. So the anterior superior quadrant is up here. So the nose is pointing to the ceiling here. So here's the malleus. Here's your cone of light. So the pearl is in the anterior superior quadrant. So if you see something like, look at that, anterior superior quadrant, little pearl, in a young child, this is probably what that is. And that's how we take it out. We make a big incision around the ear canal. Big is a relative term, but incision around the ear canal. Fold the eardrum down off the malleus and take these clusteatomas out. And there is your pearl in the anterior superior quadrant. So this patient is sitting up. So here's the top of the malleus, here's the bottom of the malleus, here's your cone of light, and here's the pearl. I mean, and it looks just like the pearl. So if you think it's a foreign body, send it to me and I'll tell you the difference. Tell you if it is a foreign body or if it isn't. So, and I'll just say it now. If you see something in the ear and you're like, wonder how I'm going to get that out, you should send it to me and let me get it out. Because I don't wonder how I'm going to get things out. Okay? If you wonder about something, you should probably take a step backwards. So, anybody ever learn how to catch a fly ball?
Yeah.
Okay. What was the first thing they told you in catching a fly ball? Step back. Too many times we step forward when we probably shouldn't. Yes.
We might get to this, no idea, but how do you test hearing in an infant or newborn?
Yeah.
Other than not responding.
Yeah. So the newborn hearing infant screening programs are done by ABRs. So auditory brainstem response. Your hearing is always working. So we can put a click into the ear. We can put electrodes across the scalp. And we can, through repetition, deliver 1,000 clicks and filter out the EEG background noise and the neural responses from the click as it goes up the hearing nuclei, and we can determine if that is intact or not. So the answer to your question is auditory brainstem response. If they fail their newborn hearing infant screening, then they would go to an audiologist and have a repeat screen. If they fail that, then they might get an opportunity to go to the operating room and have a formal auditory brainstem response, which is a much longer test than the screening test. So your hearing is always working, and so we can do an EEG filtered test called an auditory brainstem response. There are other tests that you can do as well. Your hearing apparatus is a tension unit, so we can send a sound into the ear canal and bounce it off the eardrum. So that gives us two sounds. There's a sound that bounces off the eardrum, and then there's a sound that goes through the eardrum, through the three hearing bones into the cochlea, and the outer hair cells are muscular. They have a muscular contraction, and they will retract to sound, and then they will send a sound back out the cochlea, through the three hearing bones, through the eardrum, and we can record that, called an otoacoustic emission. The simplified answer to that is if I take a jump rope and you're standing on the other end of it, and I give it a big whip, that wave will travel down to you, and a little bit of that wave will come back, and we can hear that wave. In a normal cochlea, those otoacoustic emissions will be present. So there are audiometric, audiologic ways that we can measure those things. We can also measure teenagers who are like, I can't hear. Really? I bet you can. Okay, so this is a really ugly eardrum. So this is a attic clusteatoma. This is a clusteatoma at the top of the ear in that delicate place called the pars flaccida. This is an ugly clusteatoma with just draining ear, big mess. Infection looks like this, so lots of people will show up and they'll say, like, my ear is bleeding, but it doesn't hurt. My ear is bleeding, but it doesn't hurt. I don't understand what's going on. Painless drainage is a presentation of a clusteatoma. So if it looks really ugly, it might be. So I mentioned that there's really delicate stuff around the temporal bone. So here is a clusteatoma. This is a CT scan. So we're looking up and down like this. So here is the ear canal. Here is the first hearing bone. So your external auditory canal, where you stick your finger, is perfectly and opposite the internal auditory canal. Here's a little bit of the cochlea. And so here we have skin that goes from the top part of the eardrum up and is melting away the division plane between the tegmen mastoideum and the tegmen tympani, and there's no bone where there's supposed to be bone. So there's skin trapped in the wrong place next to the brain. So if anybody ever says, why are you worried about treating this ear infection? Your response should be something along the lines of meningitis, brain abscess, and death. Okay? I mean, those are the real reasons why you would want to treat an ear infection. This picture is why we get really excited about clusteatoma, because it places the patient at risk for meningitis, brain abscess, and death. We rarely see those things in first world Oklahoma, but there's a lot of Oklahoma that's not connected to the first world. So just be aware of that. If they have ugly ears, be aware that it could look like this. I mean, I took this picture from, an Oklahoma. So another ugly ear. Okay, so when we make it off to the operating room, will, operate in the ear. So this is the space behind the ear. This is what a portion of a mastoidectomy looks like. And here's the eardrum. So here's your first hearing bone, here's your eardrum. And there's a big clusteatoma going from here all the way behind the ear canal in over the tops of the semicircular canals, which we'll talk about here in a little bit. Okay, so mentioned cochlear implants. Cochlear implants are awesome things. We want kids to get as much access to sound as soon as possible. Adults, if their understanding score is really poor, a hearing aid is not going to help a poor understanding score. So we bring patients in, we do a hearing test. A part of that hearing test is to ask them to repeat back to us cowboy, baseball, hot dog in a double-walled soundproof room. And if you can't say back to us cowboy, baseball, hot dog, and plus about 35 or 50 other words depending on the test that we're doing, if you can't say those words back to us, then you have a terrible discrimination score. And when your discrimination score gets around 50, then you're no longer really a hearing aid candidate. You need to consider some other options for helping yourself hear. About 10% of the adults who would be a candidate for a cochlear implant get one. So there are lots of people out there who need a cochlear implant. The lady that I did a cochlear implant this morning, her discrimination score was 8% in her left ear and 0% in her right ear. So 8% of cowboy, baseball, hot dog in a double-walled soundproof room is nowhere near functional. So the great thing is that I talked to her for about 4 years before she did it today. So people are very reticent to do those things. I completely understand that. But just know that about 10% of folks who need and could benefit from a cochlear implant get one. What does a cochlear implant look like? This is the part. No, there it is. This is the part that goes inside the inner ear. So your inner ear looks like a little snail shell. And so we have these little cute coiled things that go into the inner ear. And they, the sound is not normal, but the sound is functional, and the sound is much better than what they're doing with hearing aids or without hearing aids. Jeff and I, really love those patients who come back to us and are like, I didn't know the refrigerator made noise. Yes, it does. Here's an example of a bone conduction device. So if you end up having a big bad clusteatoma and you lose all of your hearing bones, then we can bypass the eardrum, the hearing bones, and we can send that sound straight to the inner ear, just like the tuning fork test does. And those work great. Those things are now cell phone compatible, Wi-Fi compatible, how we live our life compatible. So you can stream your TV, your cell phone, your whatever you want to listen to straight to those devices. So it eliminates background noise. So background noise is the killer of good hearing. So there you go. Okay. We used to do posts like this. Now we do magnets under the skin, but cute little girl. All right. So that's lecture number 1, only 5 minutes over. Next, we're going to talk about dizziness, so let's take a little break. And I'll be happy to answer any questions.